Okay, we have an absolute treat for you now as our post-break next event. This is our Ignite Early Career Showcase. You will be hearing from 5 early career faculty who will have an opportunity to briefly introduce you to their work, but just like last time, the moderator will not get a chance to introduce herself, so I wanted to introduce you to Dr. Andrea Graham. She is the director of the new MSS Division of Implementation Science. She's also co-director of the Center for Behavioral Intervention Technologies, which is a major friend and partner of our Center for Dissemination and Implementation Science, where she's also core faculty. She's a very prolific researcher, and I think most importantly to this panel, she's a very dedicated mentor. So we thought she'd be a lovely person to moderate our early career showcase. So I'm going to turn it over to her to tell you what an Ignite is and what's in store.
Thank you. I'm really delighted. This is a new addition to the Brookstone Conference, and I'm really excited to be and delighted to be the moderator of this session. Ignite is a special kind of presentation format, if you haven't had the pleasure before. Essentially, each presenter has 5 minutes to go through 20 slides, so 15 seconds each, and they auto-advance. But you're going to see, you will not feel blindsided. It's really a great format, and it's going to be really fun as a way to showcase really exciting groundbreaking work that's happening by early career scholars here at Northwestern. We won't have much time for them to give their own introductions. Please do check out their beautiful bios in your folder and packet. But we have 5 extremely talented, amazing early career assistant professors here in Department of Psychiatry, Department of Medical Social Sciences, and in Department of Pediatrics. And they're going to each give an Ignite presentation. They're sitting almost in their order. So it'll be Allison Carroll, Faith Somerset Williams. They are sitting in their order. So good job, Sarah Halseth, Ashley Knapp, and Amy Van Pelt. Actually, that order is also purposeful in terms of the progression of the research that you'll hear about. For the sake of time, as I mentioned, we won't do introductions. They'll have room for 1 question each after each one, and then we'll have 10 minutes at the end for a full panel. I'm going to stop, turn it over to our esteemed panel, and begin with Allison Carroll. Thank you.
I think this is the filler slide, yes. Oh, that's my filler slide. Okay. Hi, I'm Allison Carroll, and I am very delighted and honored to be kicking this off, and thank you in advance for your grace and compassion with this format. I'm going to be sharing about a pilot project that was implementing mental health screening and treatment in pediatric primary care. So I am an implementation scientist who has done the whole translational scope of research. I started with bench, I went to neuroimaging, I dabbled in epidemiology and clinical trials, and I landed in implementation science. And one of the reasons this has been such a great home for me is because I am trained as a clinical health psychologist in behavioral medicine, where we really focus on behavior change and getting these evidence-based treatments out to the individuals who really need them. So the problem with this project in particular that we were trying to address is that we know up to 20% of youth have impairing mental health problems as early as age 3. But we don't have great guidelines for screening and intervening on these kids in this early phase. One thing that we have found in our research, led in large part by our own Dr. Lori Wachschlag, is irritability is an incredible screenable transdiagnostic marker of many both internalizing and externalizing mental health disorders. And I'm currently in the thick of this phase. So we implemented in a pilot project screening for irritability for 24-month well-child visit and the 30-month well-child visit, referral to an evidence-based treatment, and then we did qualitative interviews with the 5 pediatric primary care providers who participated. The screener assessed both symptoms of irritability, like tantrums, as well as the impact that those symptoms have on the families, and then we provided guidance to clinicians as to when to refer, monitor, or take no action with those patients. In the 6 months that this was rolled out in a single clinic, there were 201 eligible families, and of those, about half of them ended up completing the screener, which is great. This was all delivered through the EHR. Then we included a referral to an evidence-based treatment, the family checkup, which is a family-oriented strength-based intervention that is shown to be effective for families and their young kids. So of the 100 folks who did complete the screener, about a quarter of them had positive screens indicating elevated irritability, and a quarter of them were referred to and completed treatment, which is actually a pretty good number for this type of intervention, especially in this pilot phase. And in the qualitative interviews we did with the participating pediatricians, we really wanted to just get an understanding of their perspectives of the irritability screening in general, as well as assess those barriers and facilitators to implementing this more broadly in their practices. Overall, their perspectives were really positive. So they felt that using the screener increased their clinical decision-making confidence, and that's going to decrease decision fatigue and burden on the clinicians who are already really busy. In terms of barriers, and implementing any new practice is going to be really complicated in a primary care clinic. In pediatric primary care, they're doing so much, but none of the barriers they identified were specific to the irritability screener itself. One thing that was really interesting and that we almost never see in our work is that they gave us a ton more facilitators than barriers. People are always happy to tell you about problems. They rarely tell you about the things that we can actually leverage and take away with us to rely on. So we know that we need to do more to increase the screening rates, but we can really leverage what we know already about common barriers in pediatric primary care and rely on those many facilitators to develop our implementation plan and really selecting strategies that are going to apply directly for this context with this population. Things we're thinking about are EHR integration and automation so that we're taking some of the burden off of the primary care clinic team. All of this was a pilot trial, right? And so I have a link to the full paper if you want to see more results, but importantly, it has led into the Mental Health Earlier Center, led by Drs. Lori Wachschlag and J.D. Smith. It was started about a year ago. We have some wonderful MHE representatives here. And the purpose of this center is to create multiple care pathways for these kids, to really work across projects to identify synergies in implementing various aspects, and evaluate the mechanisms of why and how implementation is working. Hopefully, the purpose of this center is to really increase the reach of screening and early intervention, to work on prevention of later mental health problems for these kids, and hopefully to inform guideline development so that this does become something that is more broad-reaching and implementable. So thank you so much for your time and attention today. I promise they're not always irritable, and I'm happy to take any questions that you have.
One question. Beyond, how'd you do it?
I'll ask a quick question. Tell us more about that 24 to 6, and you had said, oh, that's common, of that drop, and how do we then increase that drop?
Thank you. Yes, no, and this is something that we talked about as I was preparing this talk. So we actually put in this intervention because we know you can't screen for something and then not provide treatment, right? And that's one of the biggest barriers, is that they don't have enough treatment and referral options, especially out in community settings. And so the fact that we had a quarter of people who are like, yes, I agree, this is a problem for you. Yes, or sorry, for our family. Yes, it's something I have time and availability to address right now. And that they went through the entire treatment protocol. Like, there's so many barriers to that completion rate. So thinking about a quarter of people actually making it all the way through, that is huge. So thank you.
Okay. Hold on. All right. Sorry. Hi, everyone. I'm Dr. Faith Somerset Williams, and I'm really excited to talk to you today very briefly about my NIAAA-funded K23 project that's focused on bringing substance use screening and brief treatment to teens with chronic illness. I've adopted a practice to highlight my positionality related to this work. Basically, it's just a fancy way of saying how I went from this 8-year-old ballerina to faculty at Northwestern University. I'm a Black, cisgender, able-bodied woman, and I was raised in Glen Allen, Virginia. But I've lived in Chicago since 2013 when I moved to attend Feinberg's doctoral program in clinical psychology. So I come to this work with formal training in mental health and a foundation of health equity and health justice. And first, I want to start with the story of a young person who inspired this work. I met William when he was 14. He had severe arthritis that caused immense pain in his body and suffering in his spirit, and he was struggling with substance misuse. He was hospitalized often for his chronic pain. He was stabilized with opioids and discharged, but there were no substance use screening. There were no prompts in the EHR. There were no referrals upon hospital discharge, and there were no key owners in this process. And so at 19, his mother found him unresponsive. William's story is not unique. 1 in 4 teens in the US lives with a chronic illness, and they are more likely to start drinking and using drugs earlier than their peers. In a recent publication, I found that teens with chronic illness had 10 times the odds of a substance use-related ED visit compared to youth without these conditions. And youth with chronic illnesses account for most pediatric hospitalizations, yet they're almost never screened for substance use. And this makes their hospital stay a missed opportunity for intervention once their medical crises are stabilized. There is a proven approach called SBIRT, which has been tested in outpatient clinics, emergency departments, and schools. But my project's focus is not on SBIRT's effectiveness. It is testing how to make SBIRT standard of practice in pediatric hospital systems, where many of these youth interact. So how can we bring SBIRT to pediatric inpatient care in ways that work for real patients in real hospitals? IS is our approach. So we started with discussions with hospital partners, meaning caregivers, patients, and staff, to identify implementation barriers and facilitators. And so as this video rolls, I'll explain that caregivers highlighted messages about good prescriptions versus bad illicit drugs oftentimes confuse teens with chronic conditions. So they really need providers to ensure that teens understand how substance use interacts with their diagnoses so they can lead their own care. From our teen discussion, consistent themes emerge related to trust and control. Basically, teens want adults who understand confidentiality limits, talk with, not at them, about substance use, and explain how substances and their prescription medications interact. We also paired hundreds of hours of inpatient workflow observations over 18 weeks with EHR chart reviews for patients 10 and up hospitalized in the units during the observations so that we could capture activity beyond those observation windows. We found that across the inpatient journey, behavioral health gets deprioritized and specifically substance use screening is missed under time pressures. The fix is to embed SBIRT, clarify team roles, and trigger automatic substance use consults so that we can standardize discharge follow-up. Our next steps are to create a group of hospital staff, caregivers, and teen patients to help adapt SBIRT to the inpatient setting and population, and then select strategies to test in a pilot hybrid type 3 trial. Williams' chart had pain scores, meds, and discharges, but no substance screens or handoffs. We're building a model where substance screening is automatic, roles are clear, and support follows teens out the door so that teens like William are no longer missed. I want to give a quick thanks and shout out to my team. Your rigor and your heart make this work possible, and to our caregivers, teens, and inpatient providers, thank you for trusting us with your experiences. This model is for you. Oh, I'm not done. I still have some time. I want all my 5 minutes. My deepest gratitude to my mentors and advisors. Their candor and steady guidance shaped this work. We have 5 minutes. And I also want to acknowledge some extraordinary individuals at Lurie who work behind the scenes, but they have been instrumental in moving this work forward. We are so grateful for your dedication to this work. And lastly, I am very grateful to my family and to the city of Chicago, the canvas behind this work. Having lived the cost of inequity, I'm committed to doing my research justly to center the goals and the pace of impacted communities in Chicago and beyond. Thank you so much.
Time for one question for Faith. Yes.
The reason why it's hard for physicians to spot substance abuse in young people with chronic pain is because most of the physicians that treat chronic pain usually do it in much older patients.
So just to repeat, your question is about, is it difficult for providers or physicians to treat chronic pain and because they're already prescribing medications? That's one of the barriers that's come up. Oftentimes barriers related to comfortability with discussing substance use, opening Pandora's box, and screening, finding out that a youth screen's positive for substance use and not really knowing how to wrap up the conversations and or refer to treatment. And so that's the process that we're exploring with providers. That's a really brilliant question. Thank you so much.
Right. Hi, everybody. I'm Sarah Helseth, and today I'm going to be sharing with you my design philosophy that I employed in my NIDA-funded research to bring cannabis use prevention and early intervention to youth diverted from the juvenile legal system. So, my work is always driven by 4 key questions. Does the evidence support this treatment? Who needs it but isn't getting it? Is this something they actually want? And is this something that would work in a real-world context? I kind of backed into it, but those questions drove me to discover this methodology, which is called Designing for Dissemination and Sustainability. And essentially it says, let's take implementation and bring it to the beginning so that from the start, interventions are designed with the thought of how they will be implemented. The question that I focused on was, the unmet need among youth in the juvenile legal system. They have higher rates of mental and behavioral health needs, but the system itself is not always built to help them address those needs. And so in this case, I focus on diverted youth, who represent the majority of youth in the juvenile legal system and are referred out for care rather than receiving their services in-house, so to speak. And unfortunately, the system itself doesn't have the capacity to treat them out in the community. So any solution to address this challenge would have to be accessible, reducing burden, and low cost. And in addition to that, it needs to be tailored to address the specific needs and preferences of these youth so that it's acceptable. That drove me to decide on a mobile health platform and a user-engaged design approach. So in this study, I spoke with youth who then beta tested the app, and now we're in the middle of the clinical trial, but something I didn't think about was we have to build the thing. So I conducted 14 qualitative interviews with youth who had past year cannabis use and were enrolled in the diversion program to understand their needs and preferences around these 3 domains. So the question that I asked each of them was, this is what the evidence says would be helpful for you. Which of these components is most important, and how would it help you want to engage in a digital health platform? And pretty interestingly, what I found was youth kind of varied in what they were interested in getting, and it really aligned with what was motivating them to use the app. But the one common theme across all youth was motivation. They said it was the highest rated and the highest ranked, and what one youth said was, it's not something someone's just going to download the app for the awards and stuff. They're downloading it to make progress. So motivation really does have to be the key. And that was really the guiding force behind the different features that we chose. So we chose features to allow youth to set their own goals, including a custom goal. We let them interact with other youth so that they could give and receive peer support, and we let them track and log their progress around substance use goals. And something that I think is important to note is that we didn't lose these other core elements. We infused them in the features that all drove motivation so that we were engaging youth as a function to drive their behavior change. So the next thing we did was test it out. We conducted beta testing with 10 youth over 1 month. And we also had those youth complete baseline and follow-up measures so that we could also pilot our study procedures. That's another great opportunity in a pilot, is you can kind of work things out early on. So some things I do want to mention here is that our beta testers reported higher motivation to change than the youth who we interviewed during the design phase. And so I think that kind of helps inform the interpretation here, where we saw really high engagement, much higher than we would expect, especially when you consider that something like half of all apps are never downloaded or that are downloaded are never opened. So our youth were very engaged, but interestingly, the things that they used were not those things that I would hope for driving behavior change. So here you're seeing that all the youth tested the log, but we only saw them use it 2 or 3 times, whereas they were visiting the app 18 times. For some youth. And so for me here, these key takeaways are that when you're designing, you want to consider your context for your intervention. You want to engage your users and apply implementation science methods without losing those core elements for what will be effective. So as to effectiveness, I don't know if this intervention works yet. We're still running the clinical trial. We finished recruitment recently, and we're going to find out whether or not the intervention that I developed is having an effect on youth substance use. But if you want to hear about these first 2 phases, you can take a picture of this QR code. We just published phase 1 and 2 results in an open access publication in Research on Child and Adolescent Psychopathology. Thank you. And that's my family. I know.
So we have one question for Sarah. Yes. See you back there.
Dennis, I love that you're running. He's really committed to time.
Hello, thank you for your research. My question is about the chat part of the app. This is for youth who were diverted from the justice system to community-based. So I'm wondering, for the chat function, is it moderated in any kind of way? How do we make sure it's not used for the opposite of what we are looking to do?
So the question, I'm just realizing you were mic'd, so I don't need to repeat it. I also had those concerns. My background is in peer deviance, and so that was something that I was very concerned about, but I also feel very strongly that peers can be a source of positive change, just like they can be a source of risk. And so we do moderate the app now, but another thing that we did that I was really grateful for is we came up with terms of use, just like you sign when you sign up for any app, and we talk through the terms of use and say, here's what happens if you violate these terms. Immediately, everything you generate becomes moderated, and it doesn't show in the app until somebody approves of it. I will say we designed the app in 2021, it's 2025, so in 4 years, we have never had someone violate the terms of use. So far, so good. Yeah, so thank you so much.
Hello, thank you again for your patience with the Ignite presentations. So my name is Ashley Knapp. I am an assistant professor within psychiatry and behavioral science, and I'm very excited to talk to you all today about the work that I've been doing to increase access for teen mental health in partnership with public libraries. So my lab will be on the next page. Yay. So we really draw from 3 different hubs: community engagement, human-centered design, and implementation research. We also got together during the Zoom days, so these were our group pictures. So if any of you are familiar with the Alien series, this is Dr. Elizabeth Shaw. She is impregnated with an alien, and in order to survive, she needs to have a cesarean. So she goes up to this med pod, or a robot doctor, and asks for a cesarean, and the med pod responds, "This med pod is calibrated for male patients only." While a silly example from the Alien series, I think we as scientists do this a lot. It's the top-down approach, where we put all of our brilliant ideas into an intervention, and then we scratch our heads whenever it doesn't lead to the uptake or the clinical impact that we see. And I really do believe this leads to that research to practice chasm, where we have so many efficacious interventions, yet they're just not getting into the hands that need them, nor into the organizations that can sustain them. So what I've been doing for the past, I guess, 5 to 6 years is partnering with public libraries. As you can see from the Chicago Tribune from 2018, libraries have been thinking about mental health for a long time. They've even started employing social workers within their branches, trying to meet those mental health needs. What I've also learned about public libraries is they're a safe haven or a refuge for teens as well as anybody who walks through their doors experiencing mental health difficulties. And they've shifted their priorities to meet these mental health and social needs. Also, I'm a fangirl for Michael Threets. Follow him if you don't. This is my wonderful partnership from top left to top right. Mr. Robert Simmons, Mr. Jackson, Mr. Stephen Jackson, Miss LaTanya Jackson, and Mr. Alex Gutierrez. And then here are some pictures from our fun adventures. So first, we started with an adult and teen community advisory board. We worked with graphic recording artists, and you'll see her beautiful art here. I won't have time to get into the adult takeaways, but I really wanted to hone in on the teen takeaways. So we asked the teens about their strengths, and one of their strengths, they said, us, the youth, we bring passion. They also talked about the strengths are our elders in their community. They bring wisdom. But I think one of the underlying key takeaways was that the current mental health resources that we have for teens are inaccessible and insufficient. So then we wanted to talk to library workers. And what we learned through interviews was that library workers, they serve as a conduit, and that patrons that walk through the doors, they connect them to services and resources within their home community. We also learned that library workers, they're not too confident, or they don't really know how or where to identify effective and teen-specific mental health resources. And this is why the relationship is so beautiful between us, because I can bring those evidence-based resources and we can co-adapt them together. We also wanted to be sure to talk to teens. So here's a teen. I was always at the library. There's a lot of good, trusted adults. It's quiet, and sometimes in a hectic household or a hectic friend fight, you might just want to go to a place and feel welcome and feel quiet and feel calm. And this sentiment was echoed by quite a bit of the teens. They also talked about the central location of libraries. It was right down the street from their school. It was right off the metro. And most of all, they talked about, especially those with teens with marginalized identities, what a safe space it was, and how it really was safe because of the consistent presence of adults. I also did design workshops with them. I really wanted to understand, how do they experience anxiety, how do they already cope with it, and how do they feel after? So do a deep dive. This individual, will be the bottom right. So she was talking about how when she has an anxiety attack, she feels like she's high up on a building. She feels like she's gonna lash out. She watches funny videos in order to kind of calm down or manage. And believe it or not, the bottom right is her at Jimmy John's. She gets very hungry after she copes. We also wanted to be sure to have the lived experiences and the voices within our intervention. So we asked them to write stories. So it's not me, this weird white researcher lady, making these stories, but they're really authentic. And again, they're the lived experiences of the teens. We also got their ideas on the logo and the design. So they really actually liked the little bee with the glasses, but if you can see, hate bottom left. Teens are always very honest, but they did love the bee and the glasses and the sentiment of a hive and the collective of experiencing anxiety together. And this is the result. So it's called Library Be Well. And right now it has 3 components: online activities that help with anxiety management, as well as teen voices. They really wanted teen testimonials, and then mental health resources, both aggregated locally and nationally. So now we've paired up with 8 additional libraries within 89 locations, or 89 branches, and that's our next step, is just to scale it out and scale it up. So thank you so much.
Great, I can ask the question. I want to circle back to the question Katie Cohen asked earlier today about how, as an early career person, you gained trust when given her question, noting that it's not really incentivized to do that, but yet everything you did talked about how strong the partnership was. So could you just reflect on how you were able to build that trust?
Yeah, of course. I will say I came into this with an 8-week intervention, and the teens laughed at me, as did the library partners. So I will say I did a lot of growing through the past 5 to 6 years. And I think what Colleen said is just consistently showing up. So there was I received the grant in 2020. The pandemic, of course, was when that happened, and the library shut down. But every Wednesday night at 7 p.m., I would log on to this teen basically group. And I will say it was primarily a safe space for BIPOC teens, so I really also tried to gain their trust, but also understand and asked, is my white presence, is this going to affect how safe this space is? So I think just through those honest conversations, through constantly showing up, is how I've done it. And I will say that they become part of my family. One of the teen investigators, actually, she goes to our Thanksgiving, she stays, and she's the auntie to one of her, to my daughter. So I will say it's not just research, it's really fulfilling in other ways as well. But I think it does show in the research too, when the teens look at this intervention, they're like, oh, these stories are real. It's not just you doing it. So, thank you.
Could you all hear this mic? I wasn't sure if it was on. Okay. So hi, good afternoon, everyone. I'm Amy Van Pelt, and I'm honored to be here with you all today to talk about a growing portfolio of research related to the adaptation and implementation of suicide prevention among youth in Africa. So why suicide? Suicide is a global problem, but the burden of disease in low and middle income countries is substantially high. In LMICs, suicide is one of the leading causes of death among youth. And we know that we have many evidence-based practices for suicide prevention, but implementation is not optimal in LMICs. There are many gaps between what we know and what we do when it comes to suicide prevention in these settings. For example, there are few validated evidence-based tools that are available, few trained mental health professionals exist in these settings. Overall, there's really a lack of mental health resources that are available. And finally, there's often high stigma against mental health in LMICs. One region that experiences all of these gaps is Africa. The African region has the highest age standardized suicide rate, and the WHO, or the World Health Organization, has recognized this as a growing problem. And so have I. I mentioned that this is a growing portfolio of research. I'm an implementation scientist who has worked in many resource-limited settings in LMICs for over a decade, but historically I've worked in other disease areas like infectious diseases. But over the past couple of years, my partners have expressed a need to address mental health challenges among youth specifically, which in part is due to youth surviving and living older due to the success of other interventions. And specifically, there's a need to adapt and implement suicide prevention in youth across Africa. And today I'll share a high-level overview of 2 projects related to adapting and implementing prevention in Ethiopia and in Botswana. We're using the same prevention intervention, which is the safety planning intervention, and similar community-engaged methods such as human-centered design. And the first step in what we need to do is really make sure the intervention fits the context better. So what we're doing is adapting the intervention following the 8-step adaptive framework in which we are, sorry, my slides are all over the place right now. So we're following the 8-step adaptive process to adapt safety planning and our implementation strategies, where in Ethiopia, we're adapting and implementing safety planning for youth aged 10 to 18 years in outpatient hospitals in 4 regions across Ethiopia. In Botswana, we're adapting and implementing safety planning for youth aged 10 to 25 years in public schools in Gaborone. Gaborone is the capital city of Botswana, and given this age range, this includes public universities as well. There are many factors that may affect implementation of safety planning in these settings, and different contextual factors in Ethiopia and different contextual factors in Botswana require that we tailor our implementation strategies. In Ethiopia, the one strategy I want to highlight is that we're implementing the strategy of facilitation to address the lack of mental health resources that are available. And in Botswana, the main implementation strategy that we're deploying is task shifting to address the barrier of few mental health professionals that exist in this setting, where we're specifically having guidance and counseling teachers administer safety planning instead of psychologists. Across both projects, we're also deploying training as an implementation strategy via educational sessions, given the few trained mental health professionals that exist, and really the need to build capacity on all components of implementation and the workflow. As we reach different milestones in these projects, it's been really helpful to reflect on generalizable knowledge that's been gleaned across both studies. For example, we know that co-design of both adaptation and implementation is key. The intervention needs to be appropriate for the target setting, so we picked safety planning based on its brief design, for example. Adaptation is an iterative process. And finally, we need multi-level implementation strategies to address multi-level determinants in both Ethiopia and in Botswana. We're now taking what we've been learning in Ethiopia and in Botswana to a new project, hopefully, in Malawi, where we hope to adapt and implement safety planning for youth aged 10 to 25 years in HIV teen clubs in rural Malawi. And as we continue to grow this portfolio, we're really learning that reducing suicide among youth in LMICs and really across the globe requires cross-contextual reciprocal learning. This is really a global health problem that requires global health collaboration. Thank you.
We have about 5 minutes for questions for everyone, but I will launch a first question for Amy, and the rest of the group can join in, and then if others also have questions, we invite you to ask them. In line with the sort of the vision of this conference of Brookstone of really making this topic accessible to addressing youth mental health, you guys did an unbelievable job, really beautiful. So what's one of your number one things of when you got started? This was really helpful in learning implementation science. And Amy, if you could start, since yours is around the world and even, so yeah, thank you.
Question is, what was helpful in getting started in implementation in youth mental health?
Yes.
So I came from an infectious disease background, so I'm really new to mental health, actually. And something that is really helpful is that the methods are the same, regardless of what disease area, what context you're working in. So although I may have been working in HIV in Botswana, we're able to use the same determinant framework, strategies, et cetera, and bring them across contexts and now into mental health.
Thank you.
I think one thing that I really enjoyed, especially as a psychologist, is I just get to talk to a lot of people. And just people have said this already in this conference, but the importance of meeting with folks across all levels and then really building your model from that and bringing in user-centered design, like a workflow analysis I use every time I meet with any sort of clinician now, because it's just an easy way for them to relate to what we're trying to figure out, not about the intervention, but about the processes.
I think that's a brilliant question. And for me, it started with, well, I know these kids are having problems with substance misuse. Why isn't anything being done? Espert is something that's been, found effective. And it started with having conversations with providers who were like, well, these kids are too sick to be using substances. And I was like, well, actually not, because when they come and talk to me, they talk a lot about the weed that they're smoking with their friends. But they're not having these conversations with the providers, again, because the question that was posed earlier is providers aren't, opening the box, right? And so it was having the conversations, learning how to use models, implementation science models, and the mixed methods to prove that there's a problem. So that study that I highlighted that it's published, but then also to have conversations, focus groups with all key partners in the healthcare process to figure out those barriers and facilitators to getting an intervention implemented.
So for all those trainees out there, you've probably heard everybody say, I didn't know implementation science existed, and I kind of found it. But I think that what helped me most to become an implementation scientist was being open and curious and eager to solve the solution, to find solutions to problems that I was really passionate about. So I was trapped in efficacy trials, and I was like, this is great. Kids are getting effective treatment, but only the kids that live here can get it. It's not like scalable because it's so expensive to deliver. It relies on a workforce of like undergraduate students. I'm like, how can we use science to help more people? So that was the thing that drove me to implementation science.
I'll say I stumbled into it. I actually was an efficacy researcher and lived within my boundaries and was very happy with the controllability and putting everything aside. And then I got increasingly frustrated that just in digital mental health, so many interventions are collecting dust on a metaphorical shelf and not getting into the hands that need it. So I would say I actually stumbled into it before I learned all the big fancy words that implementation scientists use. But I think also a plug of you don't need to just do the work. And honestly, you'll whenever you write the grant applications, whenever you start doing the projects, you'll start to learn the language.
Yeah, don't shy away from complexity.
So this might be a slightly different way to ask a similar question, but I just want to start by saying you all are an inspiration, and it's incredible to see the work that you all are leading. It's transformative, and it really paves the way forward for impact. I guess my question is, before you started, if you were to go give yourself advice, that you know now, but you didn't know when you were getting started, I think it would be helpful for folks who are maybe getting started in the audience. What would that piece of advice be? It's kind of an overlapping Venn diagram to Andrea's question, but I do like to ask this question, especially from inspiring early career researchers.
I ended and I can start off. So when I was a doctoral student, I worked in rural Arkansas, and I worked with adolescents as well as their parents. And I remember one little girl invited me to her tea party, birthday tea party, and I was a very strict clinician-ish in training, and I just had to separate that out. So I think I would tell my past self to really lean into the community and make that a part of it, and see it as a strength rather than a weakness.
One thing that I would say, I whispered this to Ashley when the mics were off, was like, don't be intimidated by the complexity of the challenges in studies. That's something I've heard Sarah say every time we were in a meeting with one of our community partners who was like, well, this thing changed again, and now our study is totally ruined. And we're like, no, it's not ruined, it's just changing. And kind of embracing that change and capturing that change and using that information to help inform, right? Because we always propose our studies one way, but how often does it actually go exactly the way we said it was going to go? It doesn't. So embracing that kind of unpredictability and figuring out what you can learn from it.
To piggyback on the theme of trust, I would tell my younger self to also lean into trustworthiness and what that means for communities. Am I, as Faith, the faculty at Northwestern, worthy of trust, and the institution in which I represent worthy of trust? That conversation and leading conversations like that with my community partners has gone a long way for me. I also, though, unlike my colleagues, I had great training in this form of work before it was termed implementation science. Shout out to Dr. Cicchetti, Dr. Neil Jordan, and Cassandra Kizzle in the room. We did this work beforehand, and so really having that training, that grounding, and showing up for the communities impacted by the systems in which we're all situated in.
Mine's relevant to what you were saying, Faith, so I'll just jump in quickly. I think it's really helpful if you're making the pivot into implementation research to actually go and do it. So I feel like you could take a lot of didactic courses. I'm someone that teaches them, so I'm not saying they're not great. But there's a lot of didactic jargon, and until you actually do it and apply the concepts, I feel like it's really difficult to fully grasp. So that's something that I leaned into. I took my first implementation science intro course in my MPH, I think back in 2016, but then had the good fortune of moving to Penn. Renad was there. So did my very first doctoral rotation in Renad's lab to see how do you actually do implementation research. And I think it really solidified and concretized all of the concepts. So my suggestion or my advice would be, when you have the opportunity to collaborate, partner and see how it actually works in action.
Amy stole my answer.
Sorry.
One more